Hello, everyone. Thank you so much for being at our webinar tonight. My name is Jill Zhang. I'm the chair of the Women in IR committee right now. And today we have the honor of having our attending Amy Deipolyi from the Memorial Sloan Cancer Center. And she has very extensive experience treating various of tumors. And today our topic is involvement of interventional radiology in breast cancer treatment. So first, I will welcome our attending and also have Dr. Deipolyi introduce herself a little bit.
Hi, thank you so much for inviting me. My name is Amy Deipolyi. I'm an attending at Memorial Sloan Kettering Cancer Center in New York City. I originally thought when I was a radiology resident that I was going to do neuroradiology, but fell in love with IR because I love to see patients again and I love doing procedures. Now, several years later into being an attending, I've decided to subspecialize in the treatment of patients with metastatic breast cancer. So in my job at Sloan, I go to tumor board, I work closely with breast oncologists, and basically treat women with disease that is limited to certain parts of the body or disease that is painful. So either do palliative treatments for painful metastasis, or the most common referral for me is a woman who has progression of a liver metastasis despite systemic therapy. And then I target that with local regional therapy. So I'm very interested in tonight's meeting. I think this will be a really great topic, and there's an area of growth for interventional radiology. Thanks again for having me.
Thank you. We're very honored to have you here because we know the breast cancer treatment has been really developed over the past few years, and it's really great that you come here and help us to learn a little bit more about it. And we also have two presenters today. The first is Corey. Corey, do you want to introduce yourself a little bit?
Sure. Hi, my name's Corinne Diss. I'm a third-year medical student about to start my fourth year at Central Michigan University. And I am going to be applying actually to interventional radiology in the next couple months here.
Okay, great. And Emily is our second presenter. Emily?
Hi, everyone. My name is Emily. I'm another current third year, almost fourth year, who's planning on applying to interventional radiology in this upcoming year. And so I'm very excited to be talking today about some of the cool things IR can do in breast cancer.
Great. And for all of you, if you have any questions during the webinar, feel free to type under the question box, and we'll answer all the questions at the end of each presentation. Okay, so now I'll let Corinne start.
Okay. Just want to make sure. Can you see my screen now?
Yeah, we see very well.
Okay. Whoops.
Great.
Oh, sorry. I have to change it so that you're not seeing my presenting screen again. Okay, can you see it full screen now?
Yeah, and you probably have to minimize that little go to webinar box on the left corner. All right, that's perfect.
Okay. Okay, so again, I'm Corinne. I'm a third year at Central Michigan University. So I'm going to talk about 3 different articles tonight. The first article is going to discuss the interventions, the IR interventions for metastatic breast cancer. The other 2 articles are going to talk about thermoablation and chemoablation for primary breast cancers. Okay, so the first article is local regional therapies for the treatment of hepatic metastasis from breast cancer and gynecologic cancers. So breast cancer is the most common cause, or the most common women's malignancy in the United States, and it's the second leading cause of cancer death. The American Cancer Society estimates that in 2017, a total of 255,180 Americans will be diagnosed with breast cancer, and there will be 41,180 deaths from breast cancer. Right now, the statistics say that there's 1 in 8 women in the US will be diagnosed with breast cancer within their lifetime. In metastatic breast cancer, more than 50% of patients develop liver metastasis over the course of their disease. The majority of the patients in these groups are not candidates for surgical resection, secondary to the extent of their disease spread. So local regional therapies may play a role in stabilizing the hepatic tumors and or palliating cancer-related symptoms. Metastatic breast cancer to the liver presents a poor prognosis with hepatic failure causing death in 20% of patients. So minimizing toxicity and preserving quality of life is prioritized in the new trends of treatment for metastatic breast cancer. The National Comprehensive Cancer Network Breast Cancer Panel recently updated their clinical practice guidelines to reflect several emerging trends in the treatment of metastatic breast cancer. There's a shifting paradigm towards newer, less invasive, and more targeted therapies specific to the location and biology of the disease, and that's where IR will play a role. So surgical resection may play a role in the management of metastatic breast cancer patients, but few patients with isolated liver disease, limiting candidacy to less than 1% of patients. So there's guidelines for surgical resection of the metastatic breast cancer. The criteria for surgical resection means that there must be a solitary lesion less than 4 to 5 centimeters, stable disease following neoadjuvant systemic therapy, and a delay between primary lesions and metastasis of longer than 2 years. And that's because a delay of longer than 2 years is a marker for favorable biology. So the surgical outcomes are a median time to recurrence of about 10 to 36 months, 5-year overall survival rates are ranging from 12 to 75%, and tumor recurrence is seen in 60% of patients. So given limitations of surgical resection, other local regional therapies have been explored, and this article is going to go through some of those now. So thermal ablation. This may be considered in patients with tumor burden not amenable to surgery due to comorbidities, including patients with small solitary lesions, metachronous lesions, and unresectable lesions that demonstrate partial or complete response to neoadjuvant chemotherapy. The response rates from thermal ablation range from 63 to 97%, and the median survival ranges from 10.9 to 60 months. A study on thermal ablation in metastatic breast cancer has independently reported a 5-year overall survival rate of approximately 30% following radiofrequency ablation. Next, we have intra-arterial therapies. These are employed in the treatment of metastatic breast cancer to the liver in salvage setting, so patients with none or limited systemic options or during their chemotherapy breaks. So these are considered for patients who have no extrahepatic disease or they have stable limited extrahepatic disease and progression of hepatic tumors. The goal of this therapy is to target hepatic disease burden while preserving the liver function of the patient. These tumor debulking options offer palliation of abdominal pain from large hepatic masses. The treatments deliver therapeutic agents directly to the tumor vasculature, achieving a high local regional tumor doses without the toxicity profile that's seen with similar doses when you're delivering it systemically. So we have hepatic arterial infusion chemotherapy. This involves the placement of an indwelling infusion catheter into the hepatic artery following surgical implantation of a chemotherapy pump, and it delivers sustained intra-arterial chemotherapy. It's actually most commonly employed for the treatment of with metastatic colon cancer to the liver, but there is published evidence to support its application for patients with metastatic breast cancer to the liver. So the article mentioned 2 different studies. In the first study, they said they had an overall response rate of 78%. Their median time to progression of liver disease was 6 months, and median overall survival of 17 months. And then the second study said that they had a 50% response rate by response evaluation criteria in solid tumors. And that response evaluation criteria in solid tumors is actually a set of published rules that define when tumors in cancer patients improve, stay the same, or worsen. And this article actually uses that criteria quite a bit, so you'll see that again. And then also in this study, median progression-free survival was 7.9 months, and the median overall survival was 19.2 months here. Another intraarterial therapy is conventional transarterial chemoembolization, or CTACE. So this delivers cytotoxic chemotherapeutic drugs mixed with iodinated oil. This lipidol emulsifies the chemotherapy and aids visualization during its administration. So an embolic agent like particles or gel foam completes this therapy, prevents drug washout, increasing drug dwell time, and reducing systemic bioavailability, and it promotes tumor ischemia. So a study that was mentioned using CTACE says that by that RECIST criteria that I had mentioned, the partial response was seen in 13% of patients, stable disease was seen in 50.5% of patients, and progressive disease was seen in 36.5% of patients. And in this study, they had a 1 in 3 year survival rate of 69 and 33%, and their median overall survival rate was reported to be 18.5 months. Next is drug-eluting embolic chemoembolization. This involves the administration of microspheres loaded with a chemotherapeutic, which is often doxorubicin, to the tumor vasculature. So this article then mentioned 2 different studies doing the drug-eluting embolic chemoembolization. In the first study, they found that at 3-month follow-up, 58% of patients had an imaging response by that RECIST criteria with a reported median overall survival time of 47 months. And then in the second study at 3-month follow-up, they had 57% of patients had stable disease, 26% had partial response, and 17% demonstrated progressive disease. And they had a mean overall survival of 17 months. And then lastly is radioembolization. This employs small microembolic microspheres to deliver a beta-emitting isotope, which is Y90, to hepatic tumors. So in the study mentioned here, there was a partial response observed in 25.6%, and 11.6% had progressive disease by that RECIST criteria. And then based on the PET-CT, the response rate was 51%, and their mean overall survival was 11 months after the radioembolization. So this was just an image from the article. In A, this is a CT scan of an 82-year-old woman with a solitary tumor. You can see it's pretty large in A. It's 4.5 centimeters by 3.3 centimeters. And then this patient underwent radioembolization. And then in image B, that's a CT scan 5 months later, and it has a reduction in the size of that tumor to 1.3 by 1.3. So this table just combines the studies that were mentioned in the article using radioembolization for the treatment of metastatic breast cancer, and it's assessing disease control after the treatment. And disease control is defined as the complete response plus the partial response plus the stable disease by that RECIST criteria that I mentioned, and I also have it written down there on the right. So using these 6 studies of radioembolization, they found the overall disease control to be 78%. So then this is a similar table, but using the studies with chemoembolization. And here, using 6 studies, they found that the overall disease control was 59%. So there is cumulative published evidence, while it's not prospective or randomized, but it suggests that radioembolization provides lower rates of targeted disease progression than CTACE in the setting of metastatic breast cancer, which is what was highlighted in those two tables that I just showed. There is potential for combining systemic and local regional therapies for patients with metastatic breast cancer. And there's a limitation of local regional therapy that it only treats existing and targeted disease in the organ of interest, which is usually the liver. Combining therapies is especially appealing with radioembolization and radiosensitizing systemic agents that are active against metastatic breast cancer. And then local regional therapies have an acceptable safety profile, and they prove efficacious in the setting of chemotherapy that's refractory hepatic metastasis from breast cancer. So this second article is much shorter than that first article that I went through, but this is radiofrequency thermoablation in locally advanced breast cancer. So thermoablation is an easy and repeatable procedure, and it can be carried out as a day case under local anesthetics. It can be associated with other treatments like surgery, hormonal therapy, radiotherapy, and preoperative bulk reduction chemotherapy. The preliminary feasibility studies have shown that the safety and feasibility of ultrasound-guided radiofrequency thermoablation in small breast cancers, which are about less than 2 centimeters, but this report is going to document radiofrequency thermoablation in larger breast cancers with the median size of about 4 centimeters. So the materials and methods used. So there's 8 patients in the study with breast cancer treated by thermoablation over 36 months. All the patients have refused to undergo surgical treatment and chemotherapy. The median age was 71, and there was a range from 54 to 75. The median tumor size in the study was 38.5 millimeters, but there's a range from 25 to 60 millimeters. Prior to the procedure, all the patients underwent a standard preoperative workup, and then the protocol was carried out using Valley Labs cool tip RF electrode needles that were inserted into the tumor under ultrasound guidance. Then the radiofrequency generator was used to deliver a temperature of 60 degrees Celsius for 15 minutes within the tumor, and ultrasound was then used to assess the effectiveness of the treatment. And afterwards, hormonal therapy was prescribed to all the patients, so they used tamoxifen and aromatase inhibitors. So the results of this study showed that at 2 years follow-up, 5 of the patients were alive. One of the patients had undergone the thermoablation following the reduction in her tumor, but then decided to go undergo chemotherapy somewhere else and then died. All of the patients reported a good quality of life. 2 of the patients had tumor markers that returned to normal values. 1 patient had complete regression of the tumor. 2 patients had a 10 millimeter residual scar, and in the remaining 3, they observed partial size reduction of the tumor with stabilization of the disease. And then no patients had observable rapid progression of the disease. And then 1 patient who had bilateral advanced disease died 3 years after the treatment. And then this was the image from the article. It's just one of the patient's mammograms. So on the left here is the mammogram of the patient prior to thermal ablation. And then on the right is the 2 images of the mammogram after her thermal ablation. So thermal ablation is a technique that uses radiofrequency waves to generate heat and cause coagulative necrosis of tissues. It can be associated with tumorectomy to reduce the risk of local recurrence, and with preoperative chemotherapy to reduce the bulk of the tumor. And in the literature carried out on 17 different studies, authors concluded that radiofrequency ablation represents a promising therapeutic modality for the treatment of breast cancer. And then thermal ablation has several advantages. It's easy to perform, it can be carried out under local anesthesia as a day case, it's repeatable, and it's more easily accepted by patients. The use of radiofrequency ablation without surgical excision in locally advanced breast cancer seems to be a promising tool that could be useful in select cases where surgery is not feasible for the patient. In this small series, they observed significant size reduction of the tumor and stabilization of the disease in all the patients with locally advanced disease who would have undergone hormonal therapy alone. But a larger series is needed to evaluate the effectiveness, limits, and indications of thermoablation in the treatment of early and advanced breast cancer. So that was thermoablation, and then this last article is successful cryoablation of breast cancer. In this article, they present a patient case. This is a 76-year-old woman who presented for routine annual screening mammogram with remote history of prior right breast mastectomy and left breast lumpectomy, radiation therapy, and axillary node dissection. Her new mammogram showed a left breast mass in the upper inner quadrant in the anterior middle depth, equal density, irregular with indistinct margins. So she had an ultrasound done, and the ultrasound showed a 0.9 centimeter oval hypoechoic mass with a parallel orientation at the 11 o'clock position that was 1 centimeter from the nipple with indistinct margins. So she underwent ultrasound-guided vacuum-assisted core biopsy with clip placement, and the pathology from that showed encapsulated papillary carcinoma. The patient declined surgical management, so they decided on ultrasound-guided cryoablation. Her follow-up mammogram with tomosynthesis, which is a 3D mammogram, revealed no residual mass. So follow-up for her will be semi-annually with mammogram and ultrasound. So these are her images. On the right, we have her 2 images of the mammogram. So figure 1 is prior to her cryoablation, and you can see the irregular mass. And then in figure 4, that's post-cryoablation without any residual mass. And then back to the left side, those are her ultrasounds. The top image, figure 2, is showing that 0.9 centimeter oval hypoechoic mass. And then figure 3 is post-cryoablation, and it shows the ice ball formation at the site of the breast mass. So cryoablation is the process by which cell death is achieved by creating freezing temperatures and inducing cell injury and ischemia, with cell death occurring via necrosis and apoptosis. Cryoablation is currently a safe and effective treatment for breast fibroadenomas and is used for treatment of liver, prostate, and kidney tumors. Its advantages are very similar to the thermoablation, but it's easy to perform under local anesthesia and on an outpatient basis. It's well tolerated, has good cosmetic results, and it's just a promising alternative for patients who would otherwise undergo lumpectomy or who are not surgical candidates. For the cryoablation studies, there's one recent phase 2 clinical study where cryoablation was performed following surgical excision, and that demonstrated a 92% and 100% success rate in the treatment of breast cancers that were unifocal, and they were less than 1.5 centimeters and 1 centimeter. And there's a current study underway, the FROST study, that is going to use cryoablation without performing subsequent surgical excision. And then this last study mentioned, the MacArthur study, assessed the safety of preoperative single dose, this monoclonal antibody, alone and in combination with cryoablation in women with early stage breast cancer. And the combination results in the activation and proliferation of T cell subsets that may be implicated in tumor immunity. And antigen release stimulated by the cryotherapy may be exploited in systemic immune stimulation, potentially creating induced synergistic anti-tumor immunity. And I am going to leave it there because this is kind of an introduction into what Emily is going to talk about. And so that's it. Sorry, there is kind of a lot of words, but if anybody has any questions, just let me know.
I thought that was a wonderful presentation. I just wanted to mention, can you guys hear me?
Yep. Yes.
Great. Just wanted to mention that cryoablation for breast lesions has been studied a little bit more even in benign tumors like fibroadenomas. There's a pretty extensive literature. Sometimes it's a little hard for us to get those cases because the patients start with the surgeons, and the surgeons usually are going to operate. So it'll be, I think, a challenge for the future to demonstrate that, going with a local ablation would be sort of a better way to go than surgery. And I really like that the first article looking at the outcomes after TACE and radioembolization. It's a very, very helpful article. And one of the things that has come out a lot after radioembolization for both colon cancer and breast cancer, those early imaging follow-up, like in that we were talking about RECIST and the responses that people have. If you are a responder, you tend to live longer. So I think that's why having a response is so important. Although, even though it kind of looks like Y90 radioembolization produces better responses, we still don't know really if that is going to, how that will play out in terms of survival. The two techniques have never been compared directly, and neither one has been compared to just chemotherapy alone. So it's very difficult, and we really need more prospective studies.
Yeah, it sounds like it based on that article. So, but thank you.
Great. Thank you, Corinne, and thank you, Dr. Deipolyi, for your insight on the newer research that's also going on. So I'm going to share my screen now. Can everyone see it?
Yep, I can see it.
Perfect. Okay. So for my portion of this presentation, I'm going to be going over some of the newer research that's going on, and in particular, I'm going to be talking a lot about how you can use treatment of certain tumors with metastatic breast cancer to then affect other tumors throughout the body. And so I looked at 3 different papers for this, and as Corinne had kind of alluded to with her last paper, a lot of this deals with using immunotherapy in combination with either ablation or different embolizations that you can use. So the first paper that I looked at was actually written by Dr. Deipolyi, and it's about the abscopal effect after radioembolization for one patient with metastatic breast cancer. So when I first read this paper, I hadn't heard of the abscopal effect before, but what it is it's a rare phenomenon where you treat one tumor and then you get a response throughout other tumors throughout the body. It was first reported in melanoma, and it's more commonly reported in melanoma, but every now and then there are cases of breast cancer where it's reported in, but it's unknown what causes some patients to have this response, while majority do not. So for this paper, the patient who was presented is a 44-year-old woman who had a triple positive metastatic invasive ductal carcinoma. She initially had a surgery for it, a bilateral nipple-sparing mastectomy. And then about 4 years after that procedure, she had liver metastases, which then 8 years after her procedure had progressed to be metastases to also the lymph nodes, the lungs, the bone, and the brain. Her treatment course was pretty complex, consisting of first a partial hepatectomy and thermoablation of the liver mets and tamoxifen. But however, this didn't last very long, and after 1 year, her liver lesions continued to progress. She then received a course of trastuzumab, pembrolizumab, and otilimumab with no effect. And a lot of these medications I'm going to be going over on the next slide. She then received another course of chemotherapy, and then also 2 doses of an agonistic anti-0x40 monoclonal antibody, which helps to activate the immune system. And that was done in combination with thermoablation. However, her PET scan still showed progression of the tumors. And then she received a SIR radioembolization, and then within 2 months, not only her hepatic lesions decreased in size, but the extrahepatic ones did as well. And this lasted for about 4 months before it continued progressing. And then the patient unfortunately passed away almost 2 years after the radioembolization. So kind of the breakdown of her treatment, she received tamoxifen, which works against the estrogen receptor on her tumor. She also had trastuzumab, which works specifically against the HER2. And then pembrolizumab begins kind of the immunotherapy that she was receiving. And this is a monoclonal antibody against PD-1, which, as you can see in the figure on this slide, PD-1 is something that tumor cells can express to kind of shut down the T cells, which are trying to kill them. And so by blocking that, you can promote tumor cell death. And then there's otilibumab, which is a monoclonal antibody that binds to a specific receptor on both your CD8 and CD4 T cells, and also your natural killer cells to stimulate their activity. And then this anti-OX40 monoclonal antibody I'd never heard of before, but it essentially helps to activate your CD4 T cells. And then finally, the microspheres are Y90 microspheres that IR uses for radioembolization. And later on in this presentation, we'll kind of go over a little bit more of how you work those in a procedure. So this is an image from the paper, which goes over the progression. And as you can see, the patient had a pretty progressive disease in her liver and multiple lymph nodes throughout the body. But after this radioembolization in combination with immunotherapy, not only did her liver lesions, which were treated with the radioembolization, directly respond, but her lymph nodes did as well. However, unfortunately, the disease then continued to respond, as you can see in the last PET scan image. But to see this massive response throughout the body when you only treated one lesion, I thought was very cool and made me curious to kind of look into it a little bit more. And so this second paper is from a radiation therapy article, so it's radiation oncology. However, I think that there's a lot that we can learn from it and then apply to IR, and in particular using radioembolization. So this paper kind of goes over the mechanism a little bit, and it goes back to a lot of basic science from the first couple years of medical school. But in short, radiation therapy damages the DNA and then causes the death of tumor cells. And when the tumor cells die, they release their own antigens and also create a pro-inflammatory environment that activates the immune system to respond to these antigens wherever they are throughout the body, which essentially makes it so that the immune system fights the other metastases that you may not actually directly be treating. In particular, you have your dendritic cells recruited to the site where you use your radiation therapy, and then they go back to the lymph nodes and activate your T cells to then fight other areas in the body. And so this is a figure from that paper, which kind of shows how the radiation breaks down the cells, they release different antigens and then different immune modulators in order to promote the dendritic cells to the site to take up those antigens and then bring them back to essentially induce the rest of the immune response. However, the tumor cells don't take this lightly, and they produce their own cytokines, such as interleukin 10 and TGF-beta, to fight back against the immune system and kind of dampen that response. And so immunotherapy in combination with radiation is being looked at as a potential way to overcome suppression by the tumor cells. So, for example, in the patient that we looked at in the case report, otilibumab and anti-OX40 can be used to help stimulate the immune system, and the medications like pembrolizumab can be used to prevent tumor cells from inactivating the immune system. And so this paper mentioned multiple clinical trials which are looking at radiotherapy combined with immunotherapy for metastatic breast cancer. And this table kind of summarizes what radiotherapies were combined with what immunotherapies, and there's this research going on all over the country and also the world, kind of looking at how you can fight metastatic breast cancer and try to induce this abscopal effect. And so IR can be involved in this through Y90 microtreatments. The two brands that I know of are the SIR-RFS and the TheraPs. And it's essentially like any other liver embolization procedure where you find your celiac artery and use that to get through the hepatic artery to where your tumor is, and then you provide the treatments. And because you're using a radiation therapy, you need a special box to kind of keep you safe as the operator in order to protect you from the radiation and make sure that the treatment goes directly to the patient and kills the tumor cells. So I found a video that kind of goes over the procedure, and I'm going to try playing it, and hopefully the volume works. And Corinne, if you can let me know if you can't hear the volume of the video, that'd be great. We're going to see how this works.
Okay. I can't, is it talking right now?
It is.
Yeah, I can't hear.
Okay. In that case, I will just play the video and then kind kind of talk through it as I hear what's being said.
Okay, that'll work.
Okay. So videos saying, and I'll send out these links too in the discussion box if anyone wants to look at it later. But like any other embolization, you go through the femoral artery, or usually you go up to the celiac, and then you try to find your way into the hepatic artery. And a lot of times you need to keep the SIR-spheres from getting into other areas. And so you can embolize the gastroduodenal and the gastric artery before you do treatment in order to make sure that the spheres don't go to where you don't want them to go. And then you get the catheter in position, make sure that the contrast goes to the place where you want it to. And then you start getting your box ready. And then you connect them. And then the way the box works is it has a control knob that has either contrast going through on one side or the SIR-spheres go through on the other side. And it's essentially a process where you flush the SIR-spheres, and you flush the contrast, and you flush the SIR-spheres, and you flush the contrast until all the SIR-spheres are gone. And so the rest of this video kind of like goes through how you go between the contrast and the SIR-spheres until it all gets in. And then if you skip to the end, eventually you put air into the little container where the SIR-spheres were before. And then all your SIR-spheres will hopefully have entered the patient. And then at the end, because all this radiation was in this box, you don't want the box to be left nearby you. So you're going to essentially put it all into one little packet, and it goes into a radiation container. And then usually radiation safety is in these procedures, or at least the few that I've seen. And then they take it away and make sure everyone didn't get exposed to too much radiation during the procedure. Yeah, so these are two links, and I'll put them in the discussion box. But the first one is this one that goes over the procedure, and then the second one is from the TheraSpheres, and it goes over more just how the procedure works in general, why the radiation works. And so that's the procedure and how IR can be involved. And as Corinne had already kind of gone over a little bit, Y90 is pretty effective at treating these hepatic metastases. And this is one paper that I kind of wanted to look at a little bit more to see what exactly the side effects are of this procedure and what the outcomes are when you're just looking at the hepatic metastases and not really trying to get the abscopal effect. And so this is one that was included in the larger paper that Corinne had presented first with all the papers about the different methods for metastases from breast cancer. And so, as Corinne had mentioned earlier, a majority of patients are not candidates for surgical resection. Only about 10 to 20 are candidates for surgery. And so for patients who chemotherapy isn't working as well for them, you need to use radiotherapy in order to kind of provide another option to treat their metastases. So this was a study that looked at 40 patients who had failed at least one line of chemotherapy. And in fact, a majority of them had failed only one. And it kind of looked at the adverse effects and then what the outcomes were for people who were treated with Y90. And so majority of the outcomes were nausea, vomiting, abdominal pain, fatigue, anorexia, then gallbladder and biliary tree complications, but only 40% of these patients experienced them, and a majority of them, all these complications resolved by themselves. Unfortunately, one patient in the study did pass away from a pulmonary embolism that occurred 24 days after the procedure. The treatment responses tended to be very good, with complete response in 5% of patients, partial response in 26%, and then stable disease in 39%, which, as Corinne had mentioned earlier, this is a lot of times these three categories are considered to be some kind of response to the treatments. And then 29% of the patients did have progressive disease, which corresponds to a 20% increase in the lesion diameter. The median survival time was 13 months, and then the median time to progression was almost 7 months. And 32% of the patients had survived after about 2 years of this procedure. And in fact, it was found that if you added chemotherapy to this procedure, it improved the prognosis if it was given after the radioembolization. And so this is one example of a patient who we have the 3 lesions that were here before treatment, and then after the treatments, you can't really see them at all. So this was one of the patients who had a complete response. I'm not sure about the timing of the post-treatment slide though, but it's very encouraging to see that procedures like this can have such a great response. And so these are my references, and we can start taking questions now. And if Dr. Deipolyi has any other comments, it'd be great to hear them. But some just takeaways are that metastatic breast cancer can have a pretty poor prognosis, but IR can be very involved in the therapy, especially through treating the primary tumors with cryoablation, radioablation, and then also in treating the metastases. And potentially we can treat one metastases and affect multiple metastases throughout the body with this abscopal effect. Thank you.
That was a great presentation, and I really believe that Y90 radioembolization has the potential to really contribute by prompting an abscopal effect. If you look at animal studies, so in mice, they found that if the radiation is high dose but divided into multiple fractions, that's the most effective type of radiation that really stimulates the immune reaction. And it turns out that radioembolization, because you're injecting particles that decay with a certain half-life, the radiation is being administered, even though it's a very high dose, it's over a period of 2 weeks. So it's essentially almost infinitely fractionated. So just based on the animal studies, it would suggest that radioembolization would be a very powerful tool indeed to promote an abscopal effect. The other point I wanted to make about these different response rates that we see and how they seem to vary so much from paper to paper, and it can be a little confusing. It is very important to realize that in these retrospective studies, there's all kinds of differences between the different hospitals in terms of when the medical oncologist refers patients to interventional radiology for local regional therapy. So that kind of explains why we see so much variation. And it's very important to pay attention to the type of response criteria that each paper uses. So RECIST, which is the one that we kind of focused on this evening, just only takes into account the size of the tumors. But a lot of times after radioembolization or other embolizations, the tumor may be the same size, but it just stops enhancing or it stops being hot on PET. So actually, there's other types of imaging that show even better response rates after radioembolization in the setting of breast cancer. And that's just something to pay attention to when you're kind of comparing papers and trying to figure out, what's a better approach. But that was really a very interesting discussion.
Thank you for those insights. If anyone has any questions and wants to type them into the question box, please do at this time. While we're waiting for those, I just have a couple of questions for you, Dr. Deipolyi, to kind of get us started. And I'm kind of curious how often you do different procedures, like what's your day-to-day practice like for like an embolization versus a biopsy versus an ablation?
Sure. So the vast majority of our interventions in breast cancer patients are biopsies, most frequently to document metastatic disease and then to look for genetic markers. So that's like definitely the most, and also venous access, giving people ports so they can get their chemotherapy. But that by far and away in an oncology center is the greatest volume of cases just for any kind of disease. And then in terms of the local regional therapies, it's much more common for me to do radioembolization, arterial therapy, than it is to do an ablation. And in terms of, types of ablations, I've done only very few cryoablation of breast. I prefer cryoablation to heat-based in the breast. It's much more common that I might do an ablation of a solitary liver tumor or a lung tumor. So, and in those settings, I'm typically using microwave. But again, the vast majority of patients have multiple lesions, so scattered throughout the liver, so it's not really a candidate for an ablation, and we would opt to do an embolization procedure. Now, I have done TACE, chemoembolization for breast cancer, but I prefer radioembolization, A, because, from the limited data that we have, it looks like we get better responses, and B, I think that patients tolerate it better. The chemoembolization tends to have a more severe post-embolization syndrome. The Y90 radioembolization seems better tolerated, and it's just day procedures, a series of 2 or 3 day procedures, so I tend to prefer that in treating patients. And the other thing, too, is that with chemoembo, you're using, say, doxorubicin loaded into the particles, or with the Lipiodol, and often the women have seen doxorubicin before and they haven't responded, so it's hard for me to justify using the same drug, albeit locally, rather than a whole new approach with the radiation treatment.
Thank you. And between SIR-spheres and TheraSpheres, do you ever have a preference for one over the other?
That's a good question. There's been no study comparing the two in any disease prospectively. That being said, I think we haven't really seen that one is better than the other. Personally, I use a lot of TheraSphere because the administration is much more simple, straightforward, and there seems to be less of a risk of reflux because the particles are smaller, so it doesn't tend to cause like a blockage of the arteries and reflux. So for all those reasons, I tend to use TheraSphere. I also sometimes do something called radiation segmentectomy if there's just an isolated metastasis that I can't really ablate, but I'd like to give a really high dose. You can't really do that with SIR-sphere because the particles are too large, but you can do that with TheraSphere, so I tend to prefer that. In the setting of sort of usually HCC or other diseases, there's some retrospective work to suggest that in the setting of portal vein involvement, so if you don't have your portal vein, it's better probably to use TheraSphere because the particles are so much smaller. It doesn't have an embolic effect on the artery. And I think if you embolize the artery in the setting of when the portal vein is also out, it's just too much for the liver, and you can see a lot of sort of liver failure problems with their LFTs. So that would be one example of a setting where, at least theoretically, TheraSphere would be better. And there is some retrospective data to kind of suggest that.
Thank you for that answer. And another question I have, I've heard before of people potentially I've heard this for HCC before, is you have people who say aren't responding to an embolization and then you consider an ablation afterwards. Have you ever done that for hepatic metastases for breast cancer?
Not really, because usually if there has not been a response, it's usually much more diffuse disease. And ablation really works the best if it's only 1 or 2 lesions that are each less than 2.5 or 3 centimeters. So it's pretty uncommon that if they fail an embolization, I would go for an ablation. Much more common would be I start off with an ablation procedure because they only had 1 met, but then on a follow-up, they end up developing many mets. And so then I might end up doing an ablation first, but then later transitioning them to an embolization.
Great. And we presented some futures for research with breast cancer. Where do you see the prospective research going into the future, especially as someone who's probably involved in it yourself?
I think you kind of hit the nail on the head in terms of the need for combination studies, whether that be Y90 in combination with a radiosensitizer or Y90 in combination with immunotherapy. I think the only real way for us to remain relevant in this field is to kind of combine forces with systemic therapies and make our local regional therapy more effective systemically throughout the body. I think the other major theme, not just for breast cancer, but for other diseases too, is to figure out the important biomarkers that can be assessed before you treat the patient that help us predict who's going to have a response and who isn't. because obviously it would be better to just pick the people that will eventually respond to treatment, and because those people are probably going to get the most benefit.
Great. It sounds like an exciting thing that there will be a lot of work for us to do in the future as people who are interested in interventional radiology. So we have a question here from Narina DeSoma, and her question is, does being premenopausal versus postmenopausal affect IR management? For example, I understand ovarian ablation with leuprolide is only beneficial for premenopausal women, and aromatase inhibitors are beneficial in postmenopausal women. Wondering if IR management is different between these populations.
That's a really good question. And, you know, many papers have tried to look at whether hormonal markers could predict outcomes after these different therapies, and it doesn't really seem to. The only thing that I would say about that is that if a patient were on hormonal agents because they have a hormonally responsive cancer, we would definitely continue that agent, you know, before and after treatment. So, you know, but when we've looked at outcomes after, say, radioembolization, whether you're ER positive, HER2 positive, et cetera, it doesn't seem to impact how you really respond to the radioembolization.
Thank you. It looks like those are all the questions we have for now. Do you have any remaining questions, Corinne?
No, I actually, it's a little bit off topic, but I'm kind of curious about the clinical aspect of managing the patient after this. So you said you worked with the oncologist also, but after you do these local regional therapies with these patients, how often are you seeing the patients in follow-up in clinic?
That's a really good question. At our institution, we have a dedicated IR clinic where we see patients before and after our treatments. So, you know, I think there's a range of behaviors between the different doctors in our practice, whereas on one end of the spectrum, someone may continue to follow a patient for years and years after these treatments, whereas others may see them just for one post-op visit and then kind of transition them back to the oncologist. I think the best approach is somewhere in between. In terms of both ablation, say like liver or lung ablation or liver embolization procedures, my typical thinking is to get, first of all, labs 2 weeks later and like a post-op check to see how they're doing, to make sure they're kind of recovering from post-embolization syndrome or post-ablation syndrome. Labs mostly focus on liver function tests. Then imaging, follow-up imaging. So I actually have been using a lot of PET CT to follow up on my radioembolization. I find that you see a response on PET a lot sooner than you see responses on regular CT. So with a PET CT, I tend to get that 2 to 3 months after the treatment. If they're only getting normal imaging like MRI or CT, then maybe 3 months after treatment would be when I would get the follow-up imaging with a clinic visit to discuss findings. And then I sort of then get a follow-up imaging about 3 months later, so it's a 6 month time point, and then maybe extend it if they don't have any residual disease. That's for embolic therapies. And then for ablation, I would move up the first imaging to about 4 to 6 weeks. You can usually detect if there's a residual disease a little bit sooner. So we like to make sure we kind of got everything. And again, I think PET CT is very helpful in this population to detect residual disease and recurrent.
Okay, thank you very much for answering that. And I don't have any other questions. And Emily, I think you must be the only one receiving any questions in the chat box. So is there any?
Yeah, I see one more. This one is again from Narina DeSoma. And she says, in Peoria, Illinois, where I go to medical school, the breast radiologists have a very close and collaborative relationship with the local breast surgeons, pathologists, and oncologists. Can you speak to how IR can best integrate themselves into these management teams?
Yeah, so it a little bit depends on the local culture of each institution. So at my hospital, there's actually a surgical tumor board, which is on Tuesday mornings, and then a medical oncology tumor board, which is on Thursdays. And something that I learned was that going to the medical oncology meetings was much more helpful than the surgical ones, because usually the surgeons are seeing patients with like local disease. They're not usually treating metastatic patients, whereas the oncologists are normally managing that. So they don't have like a tumor board, much like there is often for liver rounds. So it can be difficult, but I think the most important thing is to basically meet a breast medical oncologist, identify yourself as being interested. They often have questions about what can be biopsied, and then kind of build your practice from there. Anytime you see, excuse me, say a breast cancer patient undergoing a biopsy of a liver lesion, ask yourself whether a local regional therapy would be helpful, and if so, give that oncologist a phone call. So even if there isn't really a proper tumor board at your institution, you can still build your practice kind of focused on the metastatic patients and building it up from biopsies even.
Thank you for that answer. And that was a great question. Kind of going off that question, do you guys ever have tumor boards where it's you and the oncologist, maybe also a surgeon, all talking to a patient at once, or is it usually just all the doctors talking to each other and then one of them talking to the patient at a time?
The tumor boards I've been to both at Mass General, NYU, and now at Sloan, it's never directly involved a patient. It's always a meeting of a multidisciplinary meeting of doctors that then present a series of patients and then have a discussion about each one. So I've never had that experience of having the patient present.
Great, thank you for that answer. And it looks like there's no more questions that have come in. So I think that will close off the webinar then. Thank you so much, Dr. Deipolyi, for coming today and sharing all your insight. I've really learned a lot. Thank you, Corinne, for all your help. You did a great job with your presentation.
Thank you.
And thank you to all our attendees who came here tonight. And I hope you guys have a great rest of your evening and a great Friday tomorrow.
Thank you. Thank you very much.
Thank you, guys.
Good night.
Good night.
Bye. Have a good night.